Good evening, all. I'm glad to see each and every one of you back. So, I just want to say, as a reminder, this series is meant to be a guide and a learning tool for those wishing to learn coding or to make a career change, those who want to invest in themselves in learning a new specialty, or decide which coding pathway is right for them. So this is meant for both new coders and experienced coders that might just need a change of scenery. So please be patient as this is aimed at both educating inexperienced coders and experienced coders in our decided topic. So tonight we are going to discuss our coding specialty, risk adjustment coding. So this is a unique form of coding that focuses specifically on the patient's disease conditions, diagnoses, and other problems. But tonight, we have three panelists on this topic. We have Gabriel Moberg, who is a subject matter expert in risk adjustment coding. He's been in here for 18 years doing risk adjustment coding. He's also an AAPC NAB member, which is the National Advisory Board. Next, we have Crystal May, who works for Norwood, and their website is norwood.com. She's a senior risk adjustment coder and also an AAPC teacher's assistant and an SME. Third, we have Kristen Cadigan. Now, Kristen is an employee at CSI and Optimum, and she's an enthusiastic risk adjustment coder and also an AAP SME. So I'd like to welcome everybody here, and let's dig in. So we're going to start with the main question. This is for Gabriel. What is risk adjustment coding?
So it's very simple. It's another payment methodology. The only thing is that we were used to fee for service, which was paying for those services that we were rendering. But this payment methodology is based on the patient's diagnosis. So we're taking into consideration those diagnoses that a population has in order to come up with a payment or reimbursement. Everything started back in 2000s, and it was just a health plans. Back then was called Medicare Plus Choice, if I'm not mistaken here. And then everything changed with the Medicare Advantage plans. So everything started from there. It has been evolving all the time. Now we just got a new payment methodology, and I'm gonna stop there because I don't want to keep answering other questions. But that basically it is what it is.
So what is the importance of risk adjustment coding in the coding world?
So it's very important because everything depends on accurate coding. So we need to know, the ICD-10 guidelines. Back then was ICD-9 guidelines. And future fundings to manage a population depends on that accurate coding. So for example, if I'm coding today, I'm coding to get those funds maybe in 1 or 2 years. So it's very important to submit accurately those codes that the patient has, those diagnosis codes that the patient has in order to get that fund in order to manage our populations. And that's where the new trendy phrase population health comes from is, you're managing those populations based on diagnosis and also quality and outcomes, which is another methodology.
How about you, Crystal? Anything you want to add to that? What is your view on risk adjustment coding and what it is, and what's the importance?
I think Gabriel covered it pretty well. Just making sure that we have proper reimbursement for providers and plans to make sure that they have what is needed for taking care of the patients, and that's the most important part, right? Is making sure we take care of patients appropriately.
Okay. So, what do they do with those diagnosis codes? Like how does that help? Like what is the importance of, when you submit proper coding? I'm so used to seeing everybody has diabetes, it's unspecified. Everybody has hypertension. Like what are some of the things that we look at? I used to work in primary care, and everybody has 85 different conditions, and they always don't change. They're always not specified, or they're all stable. So what is the risk with that? Is one patient worse off than the other, or what? How do they value those
It kind of, an easy way to explain it for understanding for those that are not involved in risk adjustment is it kind of levels the playing field, if you will, among plans, providers, you name it. You're collecting data throughout each year, sometimes retrospectively submitting it for risk adjustment. But the goal is to make sure that we are covering proper diagnosis coding for the patients for their chronic conditions, which risk adjust to make sure that their risk adjustment factor score is accurate to ensure that the providers and plans that are taking care of these patients are receiving proper reimbursement in order to make sure that they are receiving what they should. For instance, if you have one provider who has an exorbitantly large amount of patients that have significant chronic illnesses, that provider is going to naturally spend more time and more resources taking care of those patients, right? So we want to make sure that the provider is getting reimbursed appropriately, and especially in a situation, as Gabriel was mentioning, like pop health, where you have certain populations that are being taken care of as a group, if you will, that's going to be where risk adjustment comes into play.
Anything else, Gabriel?
So it used to be a fixed monthly payment for this Medicare Advantage plans. So with the risk adjustment, what we're doing is we're adjusting that fixed monthly payment that they were receiving based on those diagnoses. So it wasn't fair to give you the same monthly, the payment amount for someone who is diabetic and someone who is not diabetic, because a diabetic may need, shoes, may need insulin. So it's like, so with risk adjustment, we're making everything for her. So now we're adjusting that payment based on those diagnoses. So that's also another reason what is so important to code correctly, to identify those patients, and to provide the full picture of the patient's status to get the correct amount and funds.
Excellent, excellent. So let's switch gears and go back to Kristen. So Kristen is a coder. The code's day-to-day in adjustment. So what is your day like? Like when you code, what do you do every day? Like what's your routine?
Well, when I log in the morning, my queue, my work list, shall we say, is already there for me. And there have been days where I've logged in and I've got 10 charts left, and that's all I've got. And there's been days where I've logged in and there's 500 charts sitting there. It really depends on how much that we've received that needs to be coded and how much has already been coded. So normally my day is I log right in, I might check my email very briefly, and then I just get to work coding. I rather like it because I just get to do my thing, do the thing I was taught to do, the thing I went back to school for. And it depends on the project that I've been assigned to. I just switched gears recently into ACA risk adjustment coding, which is a slightly different animal from the CMS HCCs. So that was very interesting. And I'm also coding for a specific client right now who's got some very specific guidelines. So with all that in mind, and I get into my day, my goal is to get my charts per hour goal depends based on the project I'm on. But what I have to try to do during my day is work a mixture of big charts and little baby charts. It's no good to anybody if I completed a 5,000 page chart today in 8 hours and didn't get anything else done. That is not helpful for anybody. So it's a balance of chipping away at those big charts and working in those smaller, office visits. That's really what my day is like. Thankfully, it's a nice routine.
So when you
like routines, and occasionally we'll go into training for different projects. It depends on what the clients need.
And that's very interesting because sometimes depending on the organization and their guidelines, they may focus only on HCCs. They want you to code everything. So we know that once we get the HCC 18, we don't need the 19 or we don't need another 18, right, for that year. But maybe that organization wants to capture all all those codes. And even though there are duplicates, or we are not going to get reimbursed by another HCC 18 in this case. So it's very interesting and challenging depending the projects and also the organization and their guidelines. My recommendation, and this is something that I'm just going to point out, my recommendation is to code everything. And the reason why I'm saying this is because CMS, this is very different from other classifications and other methodologies. CMS can come next year and say that retrospectively they're going to assign an HCC to hyperlipidemia. And now we're going to have a payment for hyperlipidemia. And if we were not capturing hyperlipidemia, we're not going to get paid for hyperlipidemia. So very challenging sometimes if you have like different organizations, and also how the payment methodology works.
Yeah, sometimes it's a big shift from one mindset to another, going from CMS to ACA. And for me, bouncing back and forth between outpatient guidelines and inpatient guidelines, you have to, change your hats pretty quickly.
All right, so let's look at it this way. So when you go in, you log into your computer, Kristen, and you're in one chart. What are you looking for? Like what is the actual, like when you code, what is that coding? What do you do and how do you submit that? Like what do you specifically look for? Like what, are you looking for level of service? Are you looking for any kind of extras, like any ancillary services? What specifically makes risk adjustment coding a little different than any other coding?
Well, based on my very little bitty pool of experience, when I go into a chart, I am only looking at diagnoses codes. I never look at, CPT codes. HCPCS codes are not a part of my daily routine. It's just the ICD-10 codes. But it could be anything from infectious diseases all the way to the Z codes at the back. You never know what risk adjusts. So, after you've done it for a while, these things are always going to risk adjust unless there's a major update to the ICD-10 guidelines. And these things don't. Like I remember as a baby coder being astonished. Wait, that doesn't risk adjust? But the more I went along, it made more sense. Like, of course, osteoarthritis doesn't risk adjust. Duh, of course. So it's really just diagnosis codes, but there's a lot that could be there. Are they having a complication from a past surgery? Are they having a sequela from a past injury? Do they have an ostomy? Is that ostomy having attention performed on it? Are we cleaning it? Are we replacing it? So there's a lot that you look for, but we're not looking at, supplies that were used or level of service. Those of you who enjoy E&M coding, I applaud you. That just went over my head. Glad it's not part of my day-to-day routine.
All right, so you were talking about these conditions that do risk adjust and ones that don't. Typically, which ones don't risk adjust? What's that dividing line?
It really depends. And again, based on my very limited experience, year to year. GERD, gastroesophageal reflux disease, that had an RX HCC value. So up to October the 1st of 2022, if that was in a patient's chart and it was current, you would capture it. Now it's gone away. Now they've decided that no longer has a RX HCC value. The thing that seems to be the common denominator in the things that do risk adjust are the things that seem to have a long-term impact or could have a long-term impact on the patient's health. A hip fracture, for example, that will risk adjust. That's a pretty serious injury. I mean, you're talking about either fracturing your pelvic bone or your femur. That's very serious. That is a long recovery period. That sometimes almost always needs a surgical, repair. Something like osteoarthritis is painful and can impede quality of life, but doesn't have, I would almost say, like a systemic effect that could potentially land you in the hospital.
What about you, Crystal or Gabe? Anything you want to add to that?
So I just want to mention that I think risk adjustment coders, we are expert in ICD-10-CM. So we need to know everything about this code book and this classification. And something very important that Kristen is talking about is that we have like different methodologies. So it's not just CMS ACC. We have our XACC. We have the ACA one. We have the commercial. So you Medicaid. So you name it. After the first CMS ACC, which was back in 2000s, and I remember 412, which was all myocardial infarction, used to have a value. Used to have a value in the methodology. Anymore has many other conditions. But yeah, so it's we are experts in ICD-10, and depending the project is where you have to focus on which diagnosis may impact the methodology or not.
All right. So when you talk about methodologies, where can somebody find out information about like what these methodologies are? Is this something that you usually get from a website, or is this something that you'd have to like have handed to you, or you'd have to know where to look for?
I think this goes across the board because it's very difficult to find official coding guidelines. What I'm saying is, like, if you go, all this is in the CMS website, but it's not very easy to get to this information. No. Like the ACA, the one that she's talking about, that one I just found out maybe 2 years ago where the information was. So everything is there, but it's really difficult to navigate and explore where it is. Optum, actually, Kristen, I don't know if you know, they have like their own risk adjustment methodology, and they sell those to some health plans. So, depending, the source. So that's where you go for the information.
Mm-hmm. All right. So basically, there's every payer has their own rule. Medicare is different from Oxford, and Oxford's different from Medicaid, and Medicaid's different from say your Blue Cross. So they all look at things differently. Is there any kind of unifying trend that seems to be like any kind of hot topic in how we look at risk adjustment, or like what are some of the most, like what are the ones that kind of cross those into those methodologies? What are the big ones? What are the
Kristen or Chris are with me, but I think with this new version, the V28, they included newborn codes. So I think this is moving to standardize all those methodologies. Because remember, Medicare, this is for Medicare. That population is very, very small. So now they have all these newborn codes. So maybe other organizations or health plans are using this methodology. So I think that's a way to standardize. And I think that we are heading that way, to that direction with the CMS ACC. I don't know if Kristen believes that.
Yeah, I think it's definitely going to throw and already has kind of thrown a wrench into the engine, if you will. A lot of coders have a little bit of misunderstanding right now in the industry that we're not in V28 yet. And it's not that we are applying V28 right now for risk adjustment, but when it comes to risk adjustment, when you are doing retrospective coding, the codes that we are doing right now that we're picking up in fee for service will be put into the data for next year. That's what we'll be capturing on risk adjustment for risk retrospective reviews next year, which is when V28 will be in effect, if you will. V28 is actually already in effect for the diagnosis codes we're capturing right now.
Right now, yes.
The model itself is not going to be used until 2024, but that will be based on the data now. So it's something that we need to be very careful to make sure that we're clear about for coders that are capturing right now, because if you have a code that is in effect this year and would risk adjust on next year's model, but they think that they don't need to capture it because it's not on this year's model, that's actually going to be something that's going to cause a problem.
So what you're saying is, if a patient has one of these risk adjustment, if they have one of these conditions that does risk adjust, it doesn't really impact till next year. How does that work?
So it impacts fee for service now, but next year it will, the way that risk adjustment works in the retrospective is that the codes that we are capturing now and submitting for risk adjustment is going to help predict costs into the future. So the data we're using right now, say on a project, would be 2022 dates of service. Even though we're in current year 2023, we are currently retrospectively reviewing 2022 dates of service in order to project the amount of cost that it's going to take to take care of those patients in the future years.
Which is what we would get reimbursed or close to it.
Those funds, yeah.
Mm-hmm.
Sweet.
Yep.
All right.
So a little different than with fee for service.
So yeah, so it's very challenging when you're trying to. This is another new trendy term, transitional. Transition. How they call it? Practice transformation. When you're transforming, when you're bringing someone fee for service to the risk adjustment world, which is doing that transition, it's really hard for the provider to see the results, the outcomes, because you're going to see those results. Whatever you're doing today, you're going to see those results next year. So it's very difficult for them to see those results, either reimbursement, bonuses, or anything like that. So it's very challenging sometimes when you want to sell, a product based on risk adjustment, where you're transforming your practice from fee for service to value based, which is risk adjustment.
Yeah,
gotcha. So we do have an audience question. I'm going to bring it on the screen. So Anthony Lavelle asked, where can you find the HHS or ACO methodology? So I think this question I was asked before, but we're specifically looking for the HHS, and I don't even know what that is. What is HHS and what is ACO methodology?
That's the one that we were talking about, the ACA. So let me look it up to see if I can answer that question while you. Yeah, it's very difficult to. It is like a dashboard of news. So when you go to CMS, you're gonna see that they just drop the link there, and that's where you find the HCC. The CMS, DCC, they're more organized, but the ACA, which is the HHS, is not that organized.
Yeah. I was saying earlier that years ago when risk was becoming the new thing, I got certified. I took the test, studied the work, and learned about all the HCC models and all that. And then my boss said, we need you to download the HCC list. And it was so confusing. I basically said, nope, I'm noped out. I'm not doing this. We need to find another person, because I did have a hard time navigating Medicare as well. And this was like 6 years ago.
I can imagine going into that site for the first time and your boss asks you to download the HCC mapping list, and you're like, okay, there's like 12 of them. Which one do I use?
Yeah.
Yeah.
So it is important to know where to look to get the right information.
Right.
And what happens if by chance you pick the wrong one? God forbid. Like it's a gamble. Like if you pick the wrong one, are you going to be able to identify that, or is there a way for you to correct that?
So I can look it up. If you have their information, we can look it up and send the link.
Okay. So what we'll do, Anthony, is we'll find that out, and we'll put that later in one of the comments. We'll add the information after the presentation. So back to Kristen. So in your daily, and this also goes to Crystal, in your daily working life, and maybe Gabe too, what are some of the big no-nos you see in charts? What are some of the things that you see that you're like, this just makes my job so much harder?
Where do we start?
My personal favorite, in an era where we have all these lovely EHR layouts, handwritten charts. Oh, nothing makes me go like handwritten charts, because the stereotype, and I know doctors are very busy people. I know the stereotype exists about bad handwriting in doctors, and there's a reason it's a stereotype, because we'll get a scan chart and I'll be looking at it and I will literally zoom it into 200% on the image to try to make out the handwriting. You have to become a part-time handwriting analyst. Like, what am I looking at? And sometimes providers will write codes. And the first thing I was taught, you never code from codes. It's like, well, I can't actually read your handwriting. That could be E87, but it might be E70. What am I looking at here? So that's definitely one of mine. I find it very difficult.
How about you, Crystal? What are some of your pet peeves about reading a chart? Things that if you could take one of those providers aside and just say, no.
When it comes to providers assigning codes or when it comes to documentation practices, because those are two totally different things.
Either one. What are some of the things that just make you take 3 Advil and a big glass of water?
Trying to distinguish between copy and paste that is relevant to the visit versus copy and paste that is maybe 3 years old and has been carried forward. That can muddy the waters very quickly for risk adjustment because, again, we're looking at previous year's dates of service in some cases for retro specifically. But the other big one for us as risk coders / auditors, there's a large increase, of course, with providers doing their own coding now compared to previous years. And that has come with its own set of challenges. We're seeing a lot of inaccurate captures of high-risk conditions in inappropriate settings, such as acute strokes in primary care offices or acute DVTs, stuff like that. Things that cannot be really confirmed in the outpatient setting that need to have further evaluation with imaging and things that would specifically be, emergency department. If you're having an acute stroke, your doctor is not going to sit there and try to work you up with a regular physical exam. They're going to send you to the hospital, right? But we see acute stroke on charts all the time because they're assigned as an acute stroke in the outpatient setting, but we wouldn't actually be able to confirm that in the outpatient setting. It would be reported with signs and symptoms instead. So if anybody is interested in a risk adjustment, one thing I always encourage people to do is make sure that they are keeping up with OIG and what OIG has been doing recently. There have been a lot of risk adjustment, specifically Medicare risk adjustment audits that have been being done over the last year or so, and they are specifically targeting these high-risk diagnoses like CVAs, MIs, DVTs, neoplasms, unspecified depression, stuff like that, and they're actively going after those, and that's not going to stop anytime soon.
Oh. How about you, Gabe?
So I think going on the same, I'm having a hard time when electronic health records, they use the code description for documentation. So that's very challenging because sometimes you have, like, if they're using that description, just to give you an example, you have diabetes without complications, and then right underneath you have diabetes with vascular complications. So then you cannot capture that because that is conflicting documentation. So that's very challenging, and something that I like about what Kristen said is that we don't code from codes, and I like to include the description too, because those descriptions, they were not created for clinical documentation; they were created for the coder to select the code. So another example: diabetes with other specified complications. So where is the other specified complication? So they don't do the link, the relationship with the other complications. So at the end of the row, we can support only the 11.9, which is without complication, because we don't have the documentation of the other. So that's very challenging when you're dealing with electronic health record documentation. As Crystal said, it came with a new set of challenges. It's hard.
One thing I like to encourage coders to do is make sure that when you're evaluating for codes that have already been assigned for risk adjustment purposes, make sure you're using the narrative and not anything that is system assigned. Because that system, you're literally seeing the effects of someone going into an EMR and choosing from a pick list. I can't count the number of times that we have seen uncontrolled diabetes, and it's automatically mapped in the EMR to E1165. Anybody who is a diagnosis coder knows you cannot map uncontrolled diabetes without further specificity of hyper or hypoglycemia. That's a good example of where there's a disconnect.
That drives me bananas.
And they have to update that. The thing is that they kept the same guidelines that happened, I think, to 2016, when that was indexing to hyperglycemia. And the changes, I think, happened 2017. I don't remember, where Coding Clinic indicated that, it is not supported. The provider has to document either hypoglycemia or hyperglycemia in order to support the E1165 or the E11649, I guess.
Mm-hmm.
So that's very interesting. Yeah. And the problem list is a problem. Definitely.
Ain't it though?
Well, that sounds appropriate. The problem was the problem. Yes.
Oh, yes.
So what kind of problems the problem was problemize?
Everything.
So you have like maybe in the assessment you have diabetes, and then on the problem list you have diabetes with PVD. That's a different HCC. That's a different reimbursement for the V24. But you cannot capture it. At least I don't recommend capturing from the problem list. You need to have it at least in the assessment section or those objective areas. So that's for me a problem, because now I have to either query the provider or and also you have acute strokes there. I don't know, and then they're pulling those acute conditions to the assessment because they're following up the residuals, but the acute code is still there. so that's a problem.
Yeah, I've seen things from that have been in that problem list for 20 years. Like I was 9 years old and I fell off my scooter. Now I have a scar.
Mm-hmm. Exactly.
Purge it. And would that be something that throws off your whatever kind of coding? Like if they don't remove stuff that's no longer active.
Mm-hmm.
Like they've had the hip fracture that's been healing for 18 years, or they've had the ankle fracture that has the I don't know if you know how orthopedic codes go, but they have the end character A, S, or D. Acute problem and current treatment, a healing stage, which is identified by the letter D, or a sequela. So sometimes, like I see, they use history of like some ankle fracture, and they leave it with the letter D at the end, and not history of a fracture. It's not, like what do you think of that?
It definitely leads to a lot of problems. We see a lot of colostomy status in the problem list where there's no mention of a colostomy currently in the PE, and then you go to the surgical history and found out, oh, takedown was done. The colostomy is no longer there. And the problem list isn't updated effectively or in an often enough time or accurately in order to reflect the current standing rather than just bringing it forward consistently visit after visit after visit, much like the copy and paste.
Mm-hmm.
Gotcha. All right, so let's switch gears a little bit. Let's talk about expectations. So with your experience in the field, like what are some things that you can tell coders that they should be ready for? Like what is like your daily production? Like what are the expectations for any new applicant? Like if anybody wants to apply or learn this, what are they getting themselves into? And what do hiring managers look for in a new candidate? Like what are some things that they should kind of ramp up now if they want to get into one of these roles?
For me, understanding your diagnosis coding obviously is going to be paramount because that's what we're dealing with day in and day out, right? And your coding guidelines, you absolutely need to know those, or at least know how to reference those and how to implement them and when to apply them. And staying up to date on your guidance yearly cannot be stressed enough. Coding clinic, making sure you're staying up to date on the yearly updates, anything that's happened recently. But the first and foremost skill for coders in general, not just risk adjustment, is your researching skills. Risk adjustment specifically, you have to do quite a bit of research because we don't always have the answers right there in front of us as we're working. So you need to be able to find the information that you need in order to make the determination on whether or not that is supported. And Gabriel was mentioning, not coding from the problem list. One of the caveats to that is there are some clients out there that want you to capture from the problem list under certain circumstances with certain types of support. And you need to be able to make determinations as to what qualifies as proper support and what doesn't.
It's really hard.
It is. It can get very gray very quickly. Risk adjustment is not as black and white as everybody thinks it is.
So if a person really wants to learn risk adjustment coding, what's the best way to learn it, either in a hurry or long term? Like, what do they need to do to learn this now? Or is this a role where they can just like hop right in?
If they have a good, solid coding background for education, they've been in coding for a while, they're familiar with multiple types of diagnosis coding, different specialties, stuff like that, I can see where they could make the leap with just going on the job and having training from there. But specifically for risk adjustment, we have to kind of think a little bit differently than what you would do for fee for service. So it's really a different mindset, and there can actually be times where you have to pull both of those together. I've actually been part of audits recently where we've combined both evaluation and management and risk adjustment together in the same audits in order to give provider feedback and education. So being a well-rounded coder is always going to be a benefit. But for risk adjustment specifically, I would definitely recommend some form of training, some form of additional upskilling, whether that be through AAPC, through study guides or a course or something along those lines, or even through employers who have their own education system and training built in.
Well, you, Gabe, what do you think? What are some of the things that can be useful to a person that wants to break into risk adjustment coding?
When someone comes to risk adjustment, we're talking about, because maybe if you're working as a cardiology coder, so you're more familiar with hypertension, heart failure, but risk adjustment, as Crystal was mentioning, we need to know the whole book. So you need to you need to have a strong knowledge, pathophysiology, very clinical, and research too. If we don't know all the conditions, so we have to Google those conditions because tons of conditions. So how in the world you're gonna know all those conditions? So you need to have those skills. And definitely, clinical, there's some clients that they want you to map a diagnosis with a particular medication. So sometimes you need to Google the medication to see if the medication is used for that particular condition. Or if they're strict to another condition like insulin. Research, clinical knowledge, like pathophysiology, disease knowledge, that will be critical.
Yeah. I've had a lot of experience with a lot of research in diagnoses, and it's not really been a good one because with my search history of like being in multiple different specialties, where it be general surgery and cardiology, orthopedics, I also did a lot of work with a lot of what's the word say, infectious disease practices, and when you search for those, like Google thinks you're patient zero. Like in the last 3 days, you've looked up every different bacterial infection. You've looked up headache, chest pain. I'm getting emails for like crematoriums. You should start planning your funeral, kind of stuff. Is there ways to like prevent that? Because I still get pamphlets in the mail for like you need to like speak to like a end of life planner.
Log out of your Google account before you start searching. That's the only thing I can suggest.
At least Coding for Optum, they said these are the resources that are approved for you to use to research conditions and medications. RX list, NIH, Merck manuals.
Mm-hmm.
We have our list, and you only resort to the Bing search if absolutely nothing else works. You go do everything else first. You go to a coder coach and say, I've never seen this, and I've tried everything. What the heck is this? Because Dr. Bing and Dr. Google, they know too much sometimes.
All right. And it looks like in answer to Anthony's question, Gabe did find the resource. Like I'm going to put it on the screen. So if you, Anthony, want to like take a snapshot of that, and that's where they find the reference.
So they need to Control F, and they have to type in HTC, and then it's going, because this is like a dashboard. So once you click on that, it's a dashboard, and then you need to go to, I think it's May 12th, 2020. I think that's the latest. So you're going to see there revised VO7, ICD-10 crosswalk to HCC risk adjustment model. So that is.
One more question for Kristen and maybe Crystal and Gabe. So I see a lot of job posts, and there's a lot of people looking for risk adjustment coders, but I see a 2-year requirement in a lot of postings. They want 2 years experience as a coder. But you, Kristen, you're a brand new coder. Like, so that kind of rule and that experience that can sometimes be overcome. What are some of the things that you think that you have, or other people that are hiring can look for? Like, disregard that 2-year requirement. Like, can it be done? And it goes you for Crystal. Like, when you have team members, what are some qualities that kind of outweigh having that 2-year experience requirement?
Well, it certainly can be done, because I was just done with my CPCA exams and the ink had just barely dried on my certificates and I was applying for jobs left, right, and sideways, and CSI companies had an opening, said, as long as you have your CPCA, send us your resume. We'll do a email interview with you. And they decided to take a chance. I'm very grateful that they did. And I was lucky because Optum provided excellent risk adjustment training. I felt really well equipped to go into live production and code real people's real charts and not just the practice ones at the end of the 4-week training period. I have an acquaintance right now who is asking, so how do I get into medical coding? And I tell them, do not just buy a bunch of books and then go take the exam. Please, please, please get yourself into an accredited program. There's lots of them. AHIMA offers them, AAPC offers them. There are several online colleges that offer accredited courses. Get the accredited courses because they're very comprehensive. They cover anatomy and physiology, pathophysiology, pharmacology. They show you some of the back end of insurance and the billing side of it. And take the exam. You will not get anywhere without a certificate. So you have to, you bite the bullet, you take the exam. But other things, are you, like Gabriel and Crystal were talking about, are you good at research? Are you a self-starter? Are you disciplined? Because a lot of coding roles are now fully remote, which is fabulous, by the way. But that means you have to be able to manage your own workflow.
Mm-hmm.
You can't be sitting here scrolling on your phone and kind of like, push a button now and again. Like, you really have to be able to, get things moving. And I think maybe this is just my opinion. I think being able to walk into it with the beginner mind, like, okay, I took and passed my exams and I kind of have to pretend like I know nothing because I've never coded a real person's chart before. So that beginner Zen mindset of I don't know anything, so I just have to be open to whatever knowledge, people are going to throw my way.
Mm-hmm. So for just to address the 2-year requirement, short answer is that it depends for a lot of companies, because for staffing companies like my employer, we work with other partner companies, right? And if they put in their contract that any coders that are going to be touching their charts must have at least 3 years of experience, we don't have the ability to subvert that. We have to go based off of what they specifically want. So in that way, it can really be something that is up in the air for a coder when they're applying. But you can always talk to your recruiter and say, hey, is this a client specified experience, or are there other things that I can do or other experience I could have, such as medical records, transcription, something along those lines that could be taken in lieu of coding in risk adjustment specifically.
So one of the questions I had, I'm sorry, Gabe, if you want to add in, Gabe?
No, I think that is it.
Yeah. So I do see there are a lot of postings out there for when they risk adjust. Like, we have an 8 month project. We have a 2-month project, a year project. Do a lot of employers say, after the 8 months, we'll find you more work, or is that like 8 months and done? Like typically how do those projects work?
I would say yes, but I don't know, Crystal and Kristen too.
That's another, it depends, to be honest. It all is based on what type of capacity the partner company or the client has, how much volume there is. A lot of risk in the beginning, especially starting out, coders are going to find a very, how can I word this, seasonal aspect to risk adjustment. And those are going to be those contract positions where you're coming in for 3 months, 6 months, something until they finish what they're doing. And then some companies may hire and bring you on as full-time employees. Some may say, okay, I'm sorry, but this project's ended. We'll be in touch if we have another project come up. Or there could be times where they roll right into another project. They have something else come up and you just transfer over. And that's where the adaptability really comes into play for risk coders. You have to be able to pivot and adapt, because any project could end or start at any given point. Guidance can change on a dime when the client says, hey, update this, start using this process instead. You have to be able to switch your brain immediately and start applying that guidance.
B28 was a real example here. Like, so we were coding since January. B24, everything is fine, and then they came out with this new version that is already in place. So whatever you're coding now, it's going to affect that payment in the future. So now they either have to go back to those encounters and capture all those diagnoses that were not included in the B24 in order to, to have that funding for next year. The other one.
All right. So if a new coder lands a role in this field in risk adjustment and they want to stick with it, like what are the opportunities for maybe higher advancement, or does this lead to anything else? Is there anything beyond risk coding that anybody that's really skilled in it can move into? Because if this is a long-term thing, sometimes people need change. Taking this, does this lead to another higher position, or can you leave this area and go right into a new field if you advance?
I would say yes. I would say yes. You can, obviously, there's going to be a certain progression, natural progression, if you will, from risk adjustment coder to maybe a coder level 2 that's checking the work of, the first level coder. I know a lot of companies do coder 1, coder 2 level. And then you have risk adjustment QA, which is where somebody is actually doing the quality check, giving feedback, kind of auditing, if you will, from the risk side of things, where you're actually giving the education feedback as well in order to help coders advance. And really, in order to advance in risk specifically, it's more about making sure you're not just understanding the codes that are in front of you and how to apply the guidelines, but the back side of risk adjustment. What happens in the back end? How is this working? What is the system about? How are all of the pieces working together in the system in order to bring about the full picture for making sure that we are capturing appropriately for patients?
And then Gabriel?
Oh, yeah, absolutely. So just to give you an example, diagnosis validation. So Sinai Papura is a very controversial code. And so sometimes I see that diagnosis in the assessment section, but I don't see any physical finding in the physical exam. So maybe you are in a QA risk adjustment coder that you're going to query the provider, or maybe a CDI risk adjustment professional. So you have like several levels that you can, of course, be promoted to CDI, even though I believe that we were doing CDI before it was trendy, because I was doing CDI back in 2005. So, but now you have the CDI opportunity too. So now you have CDIs and you have the diagnosis validation, education. So something that that comes with this career, with this position, is that you need to educate either a provider, your colleagues, or you need to come up with a flyer to educate on diabetes, things like that. I think, you have a lot of opportunities.
Okay. So when you mentioned this new thing called, you said a CDI. What is CDI in this whole risk adjustment arena?
Yeah, just to give you an example, CDI, we're looking for in this risk adjustment arena. Just to give you an example, identifying signs of a condition that it hasn't been established. So you have, for example, 2 GFRs, 90 days apart. They're below 59. So maybe you're going to query based on that clinical, those lab results for CKD 3 or 4, whatever those results are. Another one, which is very controversial too, morbid obesity. So you see 35, BMI 35, and then you see diabetes. So you're going to query for morbid obesity. So that would be another clinical validation. The case that I was talking about, the senile purpura, which is another controversial diagnosis because providers, they don't do anything with it. It's just like sometimes, so that's another one that you want to validate that diagnosis, that, the actual diagnosis, not the code, the actual diagnosis. The patient has this, PE, pulmonary embolism, DVT. If they're active, you need to query them. So that's CDI too. And education, you need to add this information. Now with the B28, we need to be more specific with heart failure. Either it's an end-stage heart failure. So now if it is end-stage heart failure, it's another HCC, another value. It used to be the same value, has an unspecified code. So now you need to come up with those CDI skills.
Oh, okay. So it's not an area where once you start risk adjustment coding, you're going to be in this job for the rest of your life. No advancement. There's a lot of places they can go with this.
Absolutely.
No.
I would say they absolutely have the ability to advance. I started out as a seasonal risk adjustment coder, and now I'm helping to lead a team of almost 40 people. So it's entirely possible. It's all about making sure you are honing your craft, right? We've all put in time and money and resources and effort into becoming well-rounded coders and to put this effort into our careers, right? It's just about making sure you continue to hone your craft, because we never stop learning either. It doesn't matter how high you go or how much you do. Nobody can know everything about every coding subject, right? Risk adjustment included. The best coders and auditors, risk adjustment or otherwise, that I know, make it a point to learn something new every single day that they're on the job.
That's what I like about coding.
Absolutely.
Yeah.
Because I learn something new every day.
Mm-hmm. Yep.
All right. So we got one last question. So what are some kind of resources that they can go if they want to learn? And what's the best place each of you can recommend that if somebody wants to learn risk coding, where do they go? Crystal.
Ooh, there are a lot of resources out there. I don't want to give any school names specifically because I don't want to put anything behind any specific names, but making sure that you have all of your resources that you need for your coding guidelines, coding clinics, the CMS website, RADV reviewer guidance from the CMS site is making sure that you have the information and understanding more on the backside of risk adjustment to understand why certain things are allowed and certain things are not. The OIG audit reports are interesting to get an idea of what's currently happening in the industry and where we may be going. One resource I would recommend for information, not so much for learning how to do risk adjustment coding, would be Sherry Poe Bernard's book, Risk Adjustment Documentation and Coding. That is the risk Bible, if you will, as far as for information about the different HCCs, different conditions, how it all works. As far as learning specifically how to code, AAPC, I believe, has a CRC program that is self-paced, or they have the VILT program, which is where you can actually learn with an instructor. They also have the study guides, of course, and practice exams and all that, and they're the ones that create the exam. So it kind of stands to reason to go to the source, right?
Absolutely.
about you, Kristen? Any recommendations for what risk coders should have access to in order to properly code, or any resources?
Please have the updated ICD-10. I mean, that probably goes without saying, but it's updated every year, and the guidelines change from year to year, and the codes change from year to year. So make sure you stay on top of that, and find some good, reputable resources that you can go to. If you don't know what Waldenstrom macroglobulinemia is, you better know where to go to look for it. Do not go to Dr. Google. Do not go to Dr. Wikipedia. Merck Manual, NIH, Medline Plus, RX List. They're my top websites. I have them in my favorites bar on my work computer. So if I have no clue what I'm reading, I can go right to that and do a quick search. And I know that this is coming from medical professionals, not whoever decided to edit the page last.
Mhm.
So good, reputable research materials for when you don't know what the thing is.
And I'm
Sorry,
sorry.
I was just going to say, I would actually add on to that. Verify through more than one reputable source. Don't use just one, because errors happen, right? And looking at another reputable source could possibly give you a different perspective as well, and something that you may need to think about before you capture a code.
Mm-hmm. Mm-hmm.
All right, we have a question from Jade Flowers. This is for Kristen. She wants to know if you can list those websites.
Sure.
And this is from the LinkedIn chat. So if you want to enter on the LinkedIn, or if you want to enter here,
I'll probably, if it's okay, if I can put it in the chat here.
Yep.
Okay.
I think Teresa also saying that the OIG, this is new to me. I didn't know about that. Just released a toolkit which shows how they come to focus on certain HCCs categories. When, maybe this is a high risk list. If this is the high risk list, yes, I have seen that high risk list before.
Yeah, it's not just the high risk, Gabriel. It's the actual methodology and the stuff that they use behind the scenes, if you will,
Like
to help them arrive. Yeah. Yep.
Wow.
They just released it. I think it was Friday the 14th or 15th, something like that.
Wow, excellent. Thank you, Teresa.
All right, so we have a few minutes remaining. Does anybody in the audience have any questions for any one of our panelists that we didn't go over, or you want to ask them in regards to becoming a risk adjustment coder? So while we're waiting, I just want to thank all of you guys for coming out today. Crystal, Gabe, and Kristen. This has been a great presentation. We covered a lot of ground, and I'm actually surprised we made it to the hour mark and got through all the questions, because there was a lot of topics. We have it looks like Teresa. She said she missed a question, but these are going to be on demand. If you want to visit our LinkedIn profile, there are going to, you can watch this at your leisure. They're also going to be on our YouTube account, which you can watch as well when you decide. It looks like Douglas wants to offer something. He says there are currently 3,034 diagnosis codes that map to one of 79 HCCs. So that is a lot of codes to go over. And what does that mean when it maps to one of 79? How do you answer that, Gabriel? So 3,034 codes map to one of 79 HCCs.
Well, depending the methodology. If we're talking about CMS ACC, I think it's 5,000 or 7,000. So we have 60,000 whatever ICD-10 codes, but not all of them are included in a payment HCC category. Only those selected by CMS, and they publish the list of payment HCCs every year, and so that's where it comes from.
Mm-hmm.
All right. Well, it looks like we have hitting the hour mark. What I'm going to do next week, we're looking at doing a presentation in relation to cardiology, and we're also going to look into some presentations in the near future in regards to A&R billing as well as orthopedics. If anyone in the audience is interested in talking to me about trying to organize any other kind of medical specialty role, I'm always trying to create new topics in regards to like things like hematology, endocrinology. So if there's any topic that you guys want to hear first, I'm just going down the list. If there's anything that you think takes priority, send to me in a message on LinkedIn or in the chat, and we'll try to cover that topic. We'll try to garner some experts in those fields and create that episode. But again, I'd like to thank our panelists, Crystal May, Gabriel Merberg, and Kristen Cadigan. And thank everybody in the audience for joining us today. Thank you, and have the rest of the weekend.
Thanks, John.
Thank you.